Hi, my name is Kelly Stackhouse. I'm the lead nurse for the FINCH Service at Sandwell and West Birmingham NHS Trust. So my service is a bowel dysfunction service. So for people who've got fecal incontinence, constipation, want to poo, can't poo, for whatever reason it is that they've got these issues. We have a vast range of different treatment options available to these patients, one of which is called the low volume irrigation, or as we call it, the washout. So basically, I'm going to talk to you a little bit on how and what the washout is. Then we're going to talk about who do we use it for, and then we'll talk about at what point of our service or treatment option or algorithm do we tend to recommend or introduce this to the patient. Who do we tend to use this product for? So we tend to use it a lot for people who've got that incomplete evacuation. They feel that it's there, they just can't get the remaining out. So rather than them sitting there straining, trying to force or having to use a finger for digitation purposes, then what we do is we recommend that they use the washout after they've been to the toilet. So pass your motion as best you can. Once you think that you've finished or that's as much as you can do, then to use the washout and empty anything else that's left remaining. We also use it for people who've got post-defecatory leakage. So whether they feel that they're incomplete or not, if they've got leakage after they've been to the toilet, so later on in the day they notice they've got some seepage or leakage in their underwear or on wiping when they're passing urine, then we would recommend that after each bowel movement that they use the washout just to ensure that there's nothing else in that rectum that can potentially then leak out later on in the day. We also use the washout for people who've got obstructed defecation, so patients who've got a rectal, the bulge between the vagina and the bottom. This ensures that there's nothing left in there that can potentially leak out after. And we also use it for patients who've got a rectal stump or have got a pouch surgery. If they're getting a mucus buildup or a mucus plug that they find difficult to remove or pass, then we'll instigate and tell them to use a washout in order to get themselves and to relieve that pressure and buildup that can happen. People who have evacuatory difficulties, so the instigation of a bowel movement, so instead of them sitting, straining, pushing, then we would say to use the washout to initiate, and they can always use the washout again on completion to ensure that they're empty. To advocate a washout as well, if that patient's quite anxious or isn't really buying into a higher volume irrigation, we can use it for the interim phase. So in order to get that patient used to inserting something into the bottom and using smaller volumes of water to insert, then we will advise them to do that for a daily basis until they feel ready and comfortable and confident in order to move on to a higher volume irrigation. The other thing that we would also recommend is that you can use it as a combination treatment. So for some people, they'll use a full irrigation and a larger volume of water irrigation first thing in the morning, but then come the evening, may have a little bit of seepage or a bit of leakage or a bit of a feeling that they need to go. So we'll recommend that they use the washout of an evening as well to prevent any overnight leakage that can potentially happen. Washouts or low volume irrigation is also quite useful for our LARS patients, our low anterior section patients, as because we're not using as large a volume, we're not using as much pressure around that anastomosis in order for that to break down. But obviously it's advisable that you consult the consultant that the patient is under prior to instigating, and always leave it a duration of time before initiating any form of washout or insertion of anything from the bottom with our LARS patients. So where do we use it, or where do we see it fits in our treatment pathways? So we always start off, and I know most services do, with a conservative management. So we're looking at their pelvic floor exercises, we're looking at how they sit on the toilet, we're looking at how they pass their motion. So we will teach them and educate them in order to sit on the toilet correctly, using their tummy muscles to push rather than straining. We will get them sitting in that right position in order to allow the angles of the bottom to open freely in order to give them a better clearance. Should all of that fail, once we've looked at the diet and their exercise and their lifestyle, as well as medication manipulation, then I see it sits quite early stages, to be fair, within the pathways unlike the higher volume irrigation. But again, everybody's different, and it's very much dependent on your consultation with your patient, the rapport and the engagement. But with anything that we're inserting from the bottom, it's very important that that patient is believing in that product, and that patient knows that it's going to help them and improve their quality of life. We have great successes within our service with low volume irrigation as well as high volume irrigation. We have it's the difference between that leakage, that embarrassment, that odour, that smell. It's the difference between that patient leaving the house or not leaving the house. It's the difference between that patient having a social circle, a relationship. It's so important that that patient can take control of their bowels. And if something as a low volume irrigation is where it, is introduced into their routine, and that's the difference that can actually change somebody's life. The feedback and the empowerment of patients after they've used the device, it's unbelievable. All the information about low volume irrigation, where to use it, how often to use it, the frequency to use it, is all referred back to into the decision guide. So if you're struggling, if you've got any questions, if you're unsure, you can always refer to the decision guide as a resource tool, or you can obviously contact us as well, and we're more than happy to help and guide you in your practice. If it is that you've got the uncertainty of should I, shouldn't I, can I, can't I, then ask us. We've been doing it a long time, and if we don't know, I'm sure we know somebody that does know. Thank you.